All right. So a lot of what I just talked about, we'll talk about throughout the day, and we can talk about it. I can talk to you about it during the breaks. Concepts and ideas it should be a continued conversation because it may not be easy for you to change everything you're doing tomorrow or next week. It's a matter of practice. So, let's see. Okay, so now we're going to talk about how do I think about the heart when I'm scanning. Some of the way I think about it may be not necessary for you in your practice, but I think that the concepts can be very useful in terms of how to be thinking about the heart when you're scanning. So the segmental approach to congenital heart disease is a concept that was first described by the Von Price. I had the privilege of meeting them years ago, but they described this in 1972, how to diagnose congenital heart disease using the segmental approach. And this was done with cardiac specimens in the morgue. But it turns out the best way to apply the segmental approach very easily is with fetal cardiac imaging. So the basic idea of segmental approach is that when you look at the heart, each heart can be evaluated independently of the other. So in other words, we could have the three main segments are the atria, the ventricles, and the great arteries. And then they're connected by the so-called AV canal, the AV valves, and the conus. And there can be abnormalities of the atria, but not of the connection. There can be abnormalities of ventricles, but each segment can be evaluated independently. And this is very important. When I'm seeing a fetal heart that's very complicated, I like to just zoom in my mind and focus on one part of the heart at a time. Then once you figure out each part, then you put it all together. That's the basis of the segmental approach. Looking at each part and then putting it all together. So each part or the main segment, you need to think about how it's aligned with the next, how it's connected. You've looked at the right and left atria. Now, how are they connected? Are they aligned with the correct ventricles? Are the ventricles aligned with the correct great arteries? This is more than you may need to know, but some of you have seen this the segmental approach abbreviated with 3 different letters, which just corresponds with the viscerals, the situs or the positioning of the viscera in the abdomen and the atria go together and can be reflected in the first letter. The second letter corresponds with the situs of the ventricles. And situs of ventricles just means is it D-looped or L-looped. And the third letter is the relationship of the great arteries. It's a little more complicated than I'd like, that's why I'm not going into a lot of detail. It's not a perfect system, but it's very useful. So let's look at some of the basics of the segmental approach using echo. There's anatomy here, like the bronchi and such, that are hard to evaluate, but at the very minimum, I think when you're looking at the visceral atrial situs, first you figure out which left and which right, but then you want to see the descending ureter stomach on the left and the IVC anterior and rightward. You do not want to see a big azygos here, but you could see a small one, that would be okay, but it shouldn't be very prominent. Then, of course, when we look above the diaphragm, you want to see where is the heart? On the left, on the right, or in the middle? Then we want to look at the ventricles and the AV valves, the mitral valve and tricuspid valve. So what does the right ventricle look like? The right ventricle, of course, may not be on the right in a particular, it may be on the left. So it's really a matter of looking at the ventricle itself closely. The right ventricle, first of all, the right ventricle always, is the tricuspid valve goes with the right ventricle. And the tricuspid valve is different from the mitral valve because the tricuspid valve does not touch the septum. I need to change this picture because of the moderator band, which I'll get to, but the tricuspid valve has attachments to the septum like this. But there's no moderator band in this picture, but the right ventricle should have a moderator band. And the right ventricle is relatively heavily trabeculated compared to the left. Now the conus is just the name for the muscle that's in the outflow portion of the right ventricle, because the left ventricle does not have that type of conus. The right ventricle does. And what that means is when you're scanning, there's going to be a distance between the tricuspid valve and the pulmonary valve because of that conus on the right ventricle. Whereas on the left ventricle, without conus, there's mitral aortic continuity. They touch each other. So now we can look at the left ventricle. The left ventricle has a mitral valve that does not attach to the septum. And there's generally two papillary muscles rather than multiple on the right. And the left ventricle is relatively smooth walled. And as I mentioned, there's mitral aortic continuity, or I say here mitral semilunar valve continuity, because you might have transposition where you have the pulmonary valve coming off left ventricle, but still it's a left ventricle without that conus. So you have mitral pulmonary continuity. The hand rule is how we figure out, is the heart D-loop or is it L-loop? So once you figure out which ventricle is which, you need to figure out which is the right ventricle and left ventricle. Then you use the hand rule. The right hand should, quote unquote, fit the right ventricle, and the left hand should fit the left ventricle. Maybe I'll talk about this when we talk about heterotaxy. Right, actually, I'll talk about it now. If you look on the left, that's a normal heart. This is a normal right ventricle. This is tricuspid valve and pulmonary valve. And you see that this is a right hand, and the thumb is, if you put the palm onto the septum in the right ventricle, the thumb points through the AV valve and the fingers in the outflow. That's a normal right ventricle. The right hand fits it, so it's de-looped. Whereas here, this is also a right ventricle, but the left hand fits it on the right. This is the thumb. If you use your left hand, the thumb is on the inflow, the fingers in the outflow, but it's a right ventricle, and the left hand fits it, so it's L-looped. It's a little complicated, but we like to do it as cardiologists for completion. And actually, it might be useful to know sometimes if a ventricle is L-looped, some of those ventricles are at higher risk for heart block. So that's good in terms of counseling. So then we look at the connection, the AV connection between the atria. How are the atria and the ventricles connected? This is, as you know, an AV canal defect, but there can be all sorts of abnormalities in the connecting segment between the atria and the ventricles. But then the conus, as I mentioned, the conus is something that we usually see on the right is something on the right ventricle. The pulmonary valve comes off of that, and this conus pushes the pulmonary artery up so that there's a distance between the tricuspid valve and the pulmonary valve. Whereas usually there's no subaortic conus, but the conus is usually we see the right side, the right ventricle has a conus and the left does not, but we evaluate that independently. And then we look at ventricular arterial alignments. As you'll notice, I'm going in a veno-arterial sequence. As I'm thinking segmentally, I'm thinking situs, the visceral atrial situs, where's the stomach, where's the heart. Then I'm thinking pulmonary and systemic veins, atria, ventricles, and moving my way through. So now we're up to ventricular arterial alignments. They could be normal, there could be transposition, all sorts of abnormalities that we can see here. So how do we perform this segment? How do we actually do it? Because I talked in terms of theory. How does that translate into practice when you're actually scanning a patient?